Our next speaker is going to be Bennett Roth. He is the director of endoscopy in the medical procedure unit. In my opinion, he's an expert on everything, but he's going to tailor his expertise today on gastroparesis.
I don't know if that's a good thing or a bad thing. Expert on everything means you don't know much about anything. I've been tasked with talking today about disorders related to the stomach and specifically gastroparesis, which really, by definition, is a symptom complex that is related to poor gastric emptying or delays in gastric emptying, and there are varieties of causes. The term itself, however, I think is a bit of a misnomer because paresis generally implies permanent paralysis, permanent lack of function. And in reality, as we'll see during this talk, there's a variety of conditions that affect gastric emptying that are indeed not permanent and are reversible. The symptoms of this disorder are obvious to you, and I'm sure you know them well. The consequences are the greatest issue, and that is that it can lead to malnutrition, marked difficulty in glucose regulation, and a significant impact on quality of life. In order to really understand things about gastroparesis, I think it's helpful to spend a few minutes talking about the physiology of gastric emptying. Remember that motor function of the gut is controlled by the parasympathetic and sympathetic nervous system, by enteric neurons, and of course the smooth muscle cells within the wall of the GI tract. Parasympathetic control involves the vagal efferents, and to some degree symptoms related to gastric emptying are carried through the vagal afferents. These nerves feed the myenteric plexus of the gut, and they do not directly innervate muscle. Sympathetic control is provided by the splanchnic efferents, which emanate from the celiac ganglion, and they both supply the myenteric ganglia and non-sphincteric muscle and pylorus. The enteric nervous system serves as really an integrative circuitry between the external modulation and the sensory afferents in the gastric wall. There are cells known as the interstitial cells of Cajal, which are deep in the muscle plexus along the greater curvature, about a third of the way to a half of the way down the gastric wall, which act really as the so-called pacemaker and modulator of both function and sensory and secretory activity. Then there are also nitric oxide secreting neurons, which have a role in regulating gastric emptying to some degree, mostly in and around the pyloric sphincter. And lastly, the smooth muscle cells themselves respond to all sorts of transmitters and electrical impulses which excite the muscle membrane, producing contractions. There are two compartments of the stomach. We got to think about this as well. There's the fundus, which really acts as a receptive organ to some degree. It relaxes and allows for storage of the ingested food that we eat. And it's during this time that acid and peptic activity takes place, and to a large extent emulsifies and liquefies the solids that we eat. It's the increasing tone in the gastric fundus that leads to a pressure gradient between the upper and lower portions of the stomach and allows for advancement of the contents of the upper stomach into the antrum. It's the antrum that has contractility to a greater degree, and it's the antrum that pulverizes solid foods and reduces them in size to 1 to 2 millimeters so that they can be easily advanced and passed through the pylorus and into the duodenum, and this process is known as trituration. Between meals, the antrum also has a propulsive and antral contractility that allows for the advancement and passage of larger particles across the pylorus and into the duodenum. So with gastric emptying, solid emptying has a great reliance upon antral contractility, whereas liquid emptying relies upon a pressure gradient between the stomach and the duodenum. So what are the causes of delays in gastric emptying? Most common is idiopathic, which was really not a cause. It's just that we don't know why they are not emptying. And perhaps to some degree, post-viral syndrome, especially those associated with Norwalk or rotavirus, may account for a good portion of these idiopathic, so-called idiopathic cases. But of the other causes, diabetes is far and away the most common, and it can occur with both type 1 and type 2. Previous gastric surgeries, and nowadays the most common offending surgery are fundoplications, which can injure the vagus nerve and lead to decrease in gastric emptying. There's a whole slew of medications that have to be considered in patients who have delayed gastric emptying. These most commonly are associated with narcotic use, tricyclic agents because of their anticholinergic effects, calcium channel blockers, phenothiazines, and interestingly enough, a GLP-1 analog, exenatide, which is Byetta, which actually is used to treat insulin resistance and in diabetics. So we have a drug that's used in diabetics that may be causing more harm than good. Autoimmune dysautonomia, which when present should raise concerns about a paraneoplastic syndrome, and then of course some of the neurologic disorders such as Parkinson's disease or multiple sclerosis. Diseases affecting the fundus, most commonly this is associated with vagotomy. The accommodation of the upper portion of the stomach is reduced, therefore there's increased pressure gradient so that food gets transferred earlier from the fundus into the antrum. And as you will hear me say more than once today, increasing blood sugars have a direct correlative role between vagal function. In diabetes, there's both decreased compliance and accommodation of the function of the fundus of the stomach, and coordination and lack of coordination because of poor antral motor function, as we'll see in a moment, only worsens the problem. And in addition, many diabetics have a marked degree of heightened sensitivity to gastric distension, which leads to ongoing symptoms. Within the antrum, abnormalities in function are associated with abnormalities in rhythm, and that is, we know that the normal cyclic activity of the gastric antrum is 3 cycles per minute. You can have either bradygastria, which is less than 3 cycles, or tachygastria. Of course, the bradygastria is intuitively associated with what you would assume to be poor emptying, but the tachygastria really doesn't help them empty faster. It causes almost a spastic activity within the antrum, which in reality leads to a decrease in the ability of the stomach to empty. And the gastric pacemaker, as I've mentioned, is at the mid-portion of the greater curvature in the interstitial cells of Cajal. In antral dysfunction, autonomic neuropathies, but hyperglycemia, both acute and chronic, lead to decreased activity. And anytime you get a blood sugar above 250 milligrams %, you begin to lose vagal activity. And when it's chronic, this leads to ongoing injury and potentially some ongoing injury to the cells of Cajal and a questionable lack of trophic factors for muscle activity. So high blood sugar equals bad gastric function. Pyloric dysfunction is a little less common. In typical pyloric stenosis, there's a decrease in the inhibitory activity of nitric oxide-containing neurons, and so the nitric oxide-containing neurons, which usually promote relaxation of the sphincter, are not functioning or are not adequately doing their job, and you get a degree of spasm and increased tonic and phasic pressure within the pylorus, resulting in decreased antral emptying. In reality, in most forms of delayed gastric emptying, this is not a major player, but we can talk about its role later on. In diabetic gastroparesis, this can occur with both type 1 and type 2. It's often associated with other obvious manifestations of consequences of chronic diabetes, such as retinopathy and peripheral neuropathy. In academic or university hospitals, it's seen very commonly because of the acuity of the patients that are often referred to tertiary referral centers, and can be seen as many as 20 to 40% of diabetics. In a community setting, it's much less common, maybe 5% for type 1 and only 1% or so for type 2 diabetics. What are the issues in poor emptying in diabetes? Well, I've listed them all, but by far the most common are the tachy and bradygastria and decreased fundic compliance. Acute hyperglycemia induces both of these events. It alters proximal compliance, and it causes an increase in pyloric contractility. Chronic changes lead to abnormalities in neurotransmission, impairment of nitric oxide secretion, damage to the pacemaker cells, and ultimately dysfunction and damage to the smooth muscle. The symptoms, as you would expect, nausea, abdominal pain, postprandial fullness and satiety, and vomiting, especially a history of vomiting up of food that's been eaten and obviously undigested hours earlier, along with bloating. The diagnosis is based upon the exclusion of any mechanical obstruction, and this is oftentimes and usually sufficiently determined by a normal upper endoscopy. If there's a significant pain component, it's oftentimes helpful to get an upper GI series just to make sure there isn't any downstream obstruction beyond the reach of the endoscope. The formal diagnosis is most commonly made by scintigraphy. This is a nuclear study, which I'm sure you all know. It involves the ingestion of a 200-calorie meal that is low-fat egg white, toast, jelly, and water. It's labeled with technetium-99 sulfur colloid. And there's a bit of controversy about how it should best be done. The best way to do this is to do a 4-hour emptying study. In a 4-hour emptying study, 50% should be gone at 90 minutes, 60% at 2 hours, 90% at the 4 hour with no more than 10% left. Some people with gastric emptying dysfunction may empty the first half of their meal normally and then not empty anymore thereafter, whereas others may empty very slowly at the outset but then catch up quickly. And so a 4-hour test is the best test. Unfortunately, mostly for financial reasons, so as not to tie up a scintigrapher for 4 hours at a time, a lot of institutions, including our own, do a 2-hour study, and they report only the half time at 90 minutes. There should be 50% or more gone, and we have to accept that for what it is. We've tried to get the nuclear medicine folks to change their minds about this, but they remain steadfast that this is good enough. In reality, their own society, the Society of Nuclear Medicine, along with the American Gastroenterology and Motility Society, have all come out in favor of the 4-hour study, but it is what it is. An alternate to this is the wireless motility or smart capsule, smart pill. This is a pill that has pH, pressure, and temperature sensors and a battery life of 120 hours. Its benefits are that there's no radiation, although we all recognize the radiation associated with a gastric emptying study is minimal. It can be done as an office procedure. It assesses motility throughout the GI tract, not just the stomach. It does require, however, that PPIs be held for 7 days, H2 blockers for 3 days, any oral antacids be held for at least a day, and that no prokinetics, anticholinergics, antiemetics, or narcotics be given for 3 days. Its biggest drawback is that we have a hard time getting insurance companies to cover it because it's still viewed in many areas as an investigational agent. In reality, its accuracy is comparable to a 4-hour scintigraphy, which is excellent. And it may help in generalizing or distinguishing between pure gastroparesis and other more generalized motility disorders. This is a study that we rarely do. It's anteroduodenal manometry. It employs an expensive and special catheter that has sensors within the gastric antrum as well as in the proximal small intestine. And it can be helpful for distinguishing between neuropathic and myopathic disorders in that if there are abnormalities encountered during the initial phase of a fed meal study, and then you give that patient erythromycin intravenously, which is a motility agent that can enhance activity within the stomach and reduce abnormalities in the migrating motor complex of the duodenum. And if they respond to the erythromycin, that would certainly suggest that their muscle activity is normal. but it's a neurologic cause. If they don't respond to erythromycin intravenously, then it's quite likely you're dealing more so with a muscle disorder. This has very limited use in most cases for gastroparesis and virtually no use that I can think of in dealing with diabetic gastroparesis, which is the most common issue that we're faced with. Treatment for these disorders is multifactorial, dietary, control of the glycemia, as I mentioned, medications, nutritional support, the use of a gastric stimulator, and ultimately, if need be, more extensive surgery. Dietary factors that are of some benefit are a gastroparesis type diet, which is low in fat, low in undigested fiber, and the ingestion of small, more frequent meals. Glycemic control is critical. I would say more than 50% of the patients who are referred to us for placement of the so-called pacemaker respond well to a more intensive glucose control, and that's essential. There's no place for other interventions until everything's been done within reason to improve diabetic glucose control. And this includes a shift to insulin if they're not on that, the consideration of an insulin pump, although there is some controversy. Many endocrinologists feel that it is better, and others have said that the data does not support any true benefit in insulin control with the use of a pump. And again, I'll just reiterate the issue of avoiding exenatide or Byetta because that in of itself can delay gastric emptying. Prokinetic medications, as you know, we only really have one, and that's metoclopramide. Unfortunately, it's associated with a significant incidence of side effects such as anxiety, sedation, extrapyramidal muscular activities, and tardive dyskinesia. And the latter, especially if not recognized, can be horrific in that it may not be reversible. At least a third or more of patients who take Reglan can't handle it. And so it's not very effective or helpful in many cases. Domperidone is a safe form of Reglan, if you will. It does not cross the blood-brain barrier, so it has very little in the way of central nervous side effects. It is not available in this country by prescription, but it's relatively easily attained in Canada, Mexico, and there are many compounding pharmacies now I know in Los Angeles who can get it and make it for you. It is better than Reglan as an antiemetic, and unfortunately there are some questions that have been raised about QT prolongation, a la the cisapride issue with it, but we've used a lot of it and I've yet to see a problem. Macrolides, which are things like erythromycin or azithromycin, do have a motilin-like activity and can increase gastric motility and emptying. They're most effective when given intravenously. When given orally, it's about a 40% response rate. The problem with the drugs are that they themselves can lead to some gastric upset, nausea, and discomfort. And most significantly, the incidence of tachyphylaxis is extremely high in that after about 6 weeks they lose their efficacy. So they're not really a very effective long-term fix. Antiemetics such as phenothiazines orally or rectally can be used, and sublingual ondansetron is oftentimes very helpful as a symptom control issue. Obviously, medications that need to be avoided are intuitively to you narcotics, anticholinergics, and smooth muscle relaxants. So what about Botox? Well, this is LA, man. It's Botox or detox. So you got to be a role for Botox in almost anything we do. And in reality, there are some studies out there, especially early on, that were a bit exciting and promising in that injecting Botox into the pylorus would lead to relaxation, which we know doesn't necessarily occur adequately in diabetic gastroparesis, and did show some short-term benefits. Unfortunately, however, over time, this effect was very transient, and controlled trials that were done failed to demonstrate any appreciable ongoing benefit. And as you'll see in a few minutes, there may be some role for this in post-op gastric emptying disorders. It's important to understand that nutrition itself and nutritional status of the patient is critical to the management of this disorder. Remember that folks will lose weight with this if it goes on for prolonged periods of time, and they lose muscle mass. And it's not just skeletal muscle mass, it's smooth muscle mass, visceral muscle mass. And that in turn leads to worsening of gastric functioning potentially and an ongoing vicious cycle of symptoms and problems. So it's important that nutritional issues be recognized and dealt with. And these folks, when they're really sick, may need temporary enteral or parenteral nutrition. Of course, we favor the enteral route, and we favor using a gastrojejunectomy with jejunal feedings. Well, what about the sexy newcomer sort of on the block, and that's the gastric electrical stimulation. And we make a point of saying it's a gastric stimulator. It's not really a pacemaker. It's not like a cardiac device. It doesn't change the rhythm of your stomach so that it becomes normal and then empties. And there are really, when this was conceived, of three approaches from a engineering standpoint. There's low frequency, high energy, long pulse stimulation, which really was designed to reset the slow wave rhythm and improve upon it. And this had variable effects, but most significantly required rather large and heavy batteries and was simply not practical. So then a high frequency, low energy, short pulse stimulation device was developed, and this was not adequate to restore normal electrical activity in the stomach, but it did improve nausea and vomiting, in large part because it acts like a TENS unit. It blocks the afferent impulses through the vagus from reaching the brain. So folks feel better, although they may not necessarily empty faster. And then there's neural sequential stimulation, which is a sequential series of annular electrodes placed along the stomach, which has yet to make it to human trials. So what do we have? We've got number 2, and that is the Intera device made by Medtronic. Short-term control studies that were originally published were not terribly effective, but there were multiple open-label trials that showed this to be an effective device. And therefore, the FDA approved it as for compassionate use. It doesn't restore normal electrical activity, but it does improve symptoms. Nausea and vomiting most reliably is decreased. There's a 25% perhaps improvement in emptying, and this may occur in those folks who have tachygastria. If it dampens that degree of activity, perhaps it will improve emptying to an extent. But 80% of the folks in these non-controlled patient studies showed at least a greater than 50% reduction in nausea or vomiting, and therefore the FDA approved it as such. So if you want to use it, you have to have an IRB at your institution that will allow you to implant this device. In the long run, however, it may be more cost-effective in many cases than medical therapy. It doesn't always work. About 15% of the time, we have folks who simply have no response at all. It requires a surgical implantation, and while the overall complication rate is worrisome, you would look at a 20% rate, you think, my God, the vast majorities are very minor. The most significant ones are infection in the implantation pocket, occasional migration of the electrodes requiring reinsertion. There have been a couple of case reports of stomach wall perforation. In the largest 10-year follow-up that's been reported, I apologize, this slide sort of shrunk while it was on the thumb drive. Dick McCallum reported in I think it was in 2011, 221 patients, varied with diabetic, idiopathic, and post-surgical origins. The data was collected from between 1 and 10 years post-implantation, and the total symptom scores were obtained, the hospitalization days were measured, and the use of additional medications were looked at. The diabetics did the best. The weight increased in all groups. J-tubes were removed in almost 90%, and only 7% of them had their devices removed. At UCLA, we get more than 50 patients a year referred to us for consideration of the so-called pacemaker. The vast majority of them are not candidates for any one of a number of reasons. They're either on chronic narcotics or other medications which delay gastric emptying, or their diabetes is way out of control with hemoglobin A1Cs of 8 and 9. They don't need a pacemaker, they need a better doctor. We've implanted 12 within the last 18 months, 84% success rate. We had one pediatric patient who had the device removed because it subsequently was found that that patient did not even have gastric emptying dysfunction, but had cyclic vomiting. We've had no significant complications. Surgery is the last resort, more substantial surgery, that is. And this would consist of a feeding jejunostomy with or without a venting gastrostomy. This can be done surgically or endoscopically. And what about pyloroplasty? Well, in a study of 28 patients who had dysfunction following a variety of causes, 28 of the 28, 89% of them had used Prokinetics before the procedure, and this dropped to 14%. Gastric emptying times did improve, although not entirely to normal. 83% had subjective improvement from a symptom standpoint. If this was done in folks who also had a gastric stimulator, they had their best success. The problem is long-term results were not provided. This was a study that was done and followed for only 4 months. Subtotal or total gastrectomy, symptoms improve in 70% of patients, but of course there's no benefit in weight gain, and it's a rather morbid, significant, obviously irreversible operation. So in summary, optimize glycemic control, avoid medications which slow gastric emptying, improve nutrition either with blenderized food, supplements, enteral, or lastly parenteral nutrition. Use of prokinetics may be of help but is limited. Antiemetics may be of help but are limited. When things are not going well, consider the gastric stimulator, and if all else fails, consider more invasive and extensive surgery. Thank you.